Welcome to the Lymphoma Research Foundation's update on T-cell lymphoma webinar. I'm PJ, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time during the Q&A box on the webinar. You can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of the program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Sarah Quinlan. Sarah Quinlan is the Senior Director of Programs and Strategy at the Lymphoma Research Foundation. Welcome, Sarah.
Thank you, PJ, and thank you for each of you for joining today's webinar update on T-cell lymphoma. We'd like to thank our supporters for this program, Pfizer and Kyowa Kirin Group. Before I turn the program over to our speaker, I wanted to briefly share information about the Lymphoma Research Foundation. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. The Lymphoma Research Foundation, or LRF, is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment through promising lymphoma research and to serve those impacted by lymphoma through quality education and support services. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. Therefore, the Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge. Most relevant for today's call, LRF offers a wide range of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or at LRF's website, lymphoma.org. LRF's helpline, one of our most valued resources, can answer your specific questions about lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences and help give others strength to meet the challenges they may face. We also offer a wide range of publications that have been reviewed by lymphoma experts to ensure that you have access to the latest lymphoma information. We also have comprehensive books on understanding non-Hodgkin lymphoma. Our mobile app, Focus on Lymphoma, is also an award-winning mobile app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage lymphoma. The app is available for free at the Apple Store and Google Play. Finally, we have launched a COVID-19 Learning Center to support lymphoma patients and caregivers through these challenging times. Please feel free to visit our website to learn more about our COVID-19 resources. If you have any questions regarding what you've heard today, or if you need additional information, I encourage you to reach out to the Lymphoma Research Foundation's helpline at 800-500-9976 or by visiting our website, lymphoma.org. We have a wonderful program planned for you today, and I'm honored to introduce to you Dr. Sylvia Jain. Dr. Jain is a hematologist and oncologist at Massachusetts General Hospital Cancer Center. She is also an associate professor of medicine at Harvard Medical School. Thank you so much for speaking today. I will now hand the program over to you.
Thank you, Sarah. Thank you, Hope and Peter. Hello, everyone. My name is Sylvia Jain. I'm an assistant professor of medicine at the Harvard Medical School and a lymphoma physician scientist at Massachusetts General Hospital here in Boston. And I want to thank the Lymphoma Research Foundation for giving me an opportunity to give this webinar. I got interested into this relatively orphan disease early in my fellowship, and I have been fortunate to pursue research and clinical care focused on this disease here in Boston. So this is just an outline of the talk today. We will go over some basic facts about peripheral T-cell lymphoma, diagnosis, biology, distribution, and updates in its classification. We will then go over various treatment strategies, both in the upfront or the first-line treatment of patients with T-cell lymphomas, and also in the subsequent treatments. We will talk about novel and upcoming therapies, including clinical trial updates. And then most importantly, we will have enough time, hopefully about 15 to 20 minutes towards the end, for questions and answers. I will also be able to share contact information for myself here so that you can always get in touch with me should you ever need to. So before we talk about T-cell lymphomas, I think it's really important to understand where they arise and how they arise and what are they. T-cell lymphomas are cancers of T lymphocytes. And what are T lymphocytes? So as you all know, our blood has three major components. It is the white cells that help us fight infections, the red cells that carry oxygen and allow us to breathe and function, and the platelets that form a clot when we get cut and put a patch so that we don't bleed out. Now, just the way one size does not fit all, similarly, our body is continuously being attacked by antigens, both from outside and from inside. So just one kind of white cell is not enough to deal with all these various stressors. And so the body has developed this really nice mechanism of differentiating these white cells into multiple types. And this process starts in the bone marrow, which is where the stem cells are made. Now, a question that's often asked to me in the clinic when I'm seeing patients with T-cell lymphomas is, where is the bone marrow? The bone marrow is the soft red tissue inside the inside the bones of our body, and they are in every bone. There may be more or less of the bone marrow and the tissue based on the size of the bone. So, for instance, the hip area, which is where, as you guys know, bone marrow biopsies are done, is one such area where there's a lot of bone marrow. And so in these areas, the stem cells get made. They are then, they become a little bit more differentiated and a little bit more committed as to what kind of blood cell they want to give birth to. As part of that, the ones that become a little bit more committed to giving rise to the lymphocytes are called as the progenitor lymphoid cells. And these progenitor lymphoid cells make their way from the bone marrow to the thymus. And thymus is like the training station for these lymphoid progenitor cells. This is precisely where the development of T cells happen, and they undergo a bunch of maturation and differentiation processes so that they become mature and functional and that they are ready to take on their job. The way I think about this is like are the cops at that are in training. And so when they are in training, they are here in the thymus and they become trained. That is, they become functional, they become mature, and they at that point leave the thymus and get into peripheral blood and lymph nodes. And as you can see here on the right, we have a cartoon of all the different lymph node stations in the body, and you can see they're distributed everywhere. And so this means that lymphomas or T-cell lymphomas that arise out of these T lymphocytes can affect any of these nodal stations that are in your body. And some of them you can feel better, just where the skin is very thin. There are some are deep-seated in the body, and it's really hard to feel them. So some facts that we should think about when we are discussing T-cell lymphomas. So roughly about 80,000 cases of non-Hodgkin's lymphoma are diagnosed every year in the United States. A very small subgroup of that, about only 10 to 15%, are T-cell lymphomas. The majority of the other non-Hodgkin lymphomas are B-cell lymphomas. Out of these 10 to 15% T-cell lymphomas, We further have many different subtypes. The most common subtype is listed here. It's the peripheral T-cell lymphoma not otherwise specified, commonly known as PTCL-NOS. The angioimmunoblastic T-cell lymphoma, or it's called as AITL, and the anaplastic large cell lymphoma, which is further divided into the ALK positive and the ALK negative subtypes. So I think it's very important for me to recognize and emphasize here that T-cell lymphomas are exceedingly rare and they're very heterogeneous, because in just 5 seconds, I was able to tell you in one bullet point how many different subtypes are there. Hence, it's imperative to be seen by a T-cell lymphoma expert early in the course of your diagnosis so that the appropriate action in terms of management can be taken and your pathology can be verified. Most of the T-cell lymphomas are post-thymic in origin, which means that they arise from T cells that are mature and they're very committed and functional. They mostly affect older adults and mostly are much more common in men than in women. Now, one of the questions that is often asked to me in the clinic is, how did this happen? How did I end up with a T-cell lymphoma? And the answer, which we will get to in a few seconds, is really complex because I think a wide variety of mechanisms play a role in the sequential development of this malignancy. One of the common questions that comes up is that, are there any particular viral infections that are associated with T-cell lymphoma? And yes, there are. And the two that are most noteworthy and have clear associations are the EBV, or the Epstein-Barr virus infection, and the HTLV1 virus. There are, you may have heard of patients that have developed lymphomas related to breast implants. And this is a rather uncommon, but now increasingly being recognized entity of T-cell lymphomas. I wanted to spend just a few seconds to talk about the geographic distribution of these common T-cell lymphomas. So this is a busy slide, but I guess what I wanted to show is that the most of the T-cell lymphomas, especially the 3 most common subtypes that are denoted here in the as the blue circle, which is the peripheral T-cell lymphoma NOS, the light blue, which is the anaplastic large cell lymphoma, and the orange, which is the AITL, or the angioimmunoblastic T-cell lymphoma, more or less they have very similar geographic distributions throughout the world. And so there is no particular pattern that we see here in the US that is unique relative to the rest of the world. However, there are certain subtypes of T-cell lymphomas, such as the extranodal NK T-cell lymphomas, that have a very clear association with the Epstein-Barr virus, that definitely have more selective geographic distribution, such as they are much more commonly found in Asia, Central America, and South America here. And this is coming back to what is going on. Why does the body develop T-cell lymphomas? And I think I wish I had one answer, but as always in medicine, the answer is complex, and then there are multiple mechanisms that are responsible. It starts all the way from the surface of the T cell, that they are very active, they're very activated, and they have been activated over a period of time. They are many times exhausted, and they are able to evade the immune surveillance of the body. There are a lot of T-cell lymphomas where there are recurrent alterations going on in their genes. There are also alterations that are going on in the DNA and the proteins that turn on and off the genes in these T lymphocytes. And eventually, because of these multiple mechanisms that play a role, you end up with very altered signaling that happens in these cells, including metabolic changes, and eventually a T-cell lymphoma transforms. This, as you may know, that in the B-cell lymphoma, non-Hodgkin's lymphoma world, there has been a lot of emphasis given to the cell of origin. Fortunately, because of a lot of genomic studies that have been done in T-cell lymphomas, we are now slowly beginning to understand what is the T lymphocyte that is giving rise to this T-cell lymphoma. And as always, there are a variety of different T lymphocytes that give rise to different kinds of T-cell lymphomas that's outlined here, where you can see the THF, which is the T follicular helper T cell, is likely the cell of origin for angioimmunoblastic T-cell lymphoma, whereas the TH1 and the TH2 kind of CD4 T cells that probably give rise to the two most common types of peripheral T-cell lymphomas, the GATA3 overexpressing and the TBX21 overexpressing lymphomas. Similarly, Tregs have been implicated to be likely the cell of origin for adult T-cell lymphomas. And then finally, there is a very small subset of T-cell lymphomas that arise from the gamma delta T-cell lymphoma. This likely contributes that this is likely responsible for only about 5 to 10% of all the T-cell lymphomas, because majority of the T-cell lymphomas are of the alpha-beta subtype. I just would like to mention here that while we are increasingly starting to understand this, there is a lot that still remains to be understood, and there is a lot of plasticity involved in the modeling of these T cells, and hence it's very possible that the tumor may not be completely identical to the cell it originated from, partly because of the cytokines and the tumor microenvironment that play a role in the shaping of these T-cell lymphomas. Given that we now have a little bit more sophisticated understanding about the cell of origin and the different subtypes of T-cell lymphomas, I think it's important to look at these mature T-cell lymphomas in terms of their location. So as shown here, a lot of the T-cell lymphomas, especially the three most common types that we will be talking about today, the peripheral T-cell lymphomas, the NOS, the AITL, and the anaplastic large cell lymphomas, are predominantly nodal in origin. However, there are other subtypes of T-cell lymphomas, such as the NK T-cell lymphomas that involve other extranodal areas, or the hepatosplenic T-cell lymphomas, the breast implant ALCL that we spoke about. Finally, there are leukemic and cutaneous versions of T-cell lymphoma as well, where either those are the primary targets of involvement or sites of involvement, or they are a secondary site of involvement. I think it's imperative to mention that a right diagnosis in a rare and a heterogeneous disease like T-cell lymphoma is imperative. I think it is also important to mention that a fine needle aspiration, which is often done as a first response to any tumor that's found, is not sufficient, and hence either a PET-guided or a CT-guided excisional biopsy or a cold needle biopsy is highly warranted. It's important, given the increasing heterogeneity in the different subtypes of T-cell lymphomas. I think it's very important that an expert hematopathologist, a lymphoma hematopathologist, is involved in making the diagnosis by performing the right set of studies, such as flow cytometry, immunohistochemical staining, cytogenetics, FISH, and in this day and age, I think it's safe to say that a lot of academic and tertiary centers are doing next generation sequencing to get more information about the molecular machinery and alterations going on in specific lymphomas. And these could potentially be leveraged down the road to develop more targeted therapies that are personalized to patients and can lead to more precise targeting of these lymphomas. I think that PET and a PET CT has now become the standard of care for most lymphomas, including T-cell lymphomas. However, if you are at an institution where this is not readily available, I think you should talk to your clinician about getting really high quality CT scans. I think it's also very important to mention that staging alone is not prognostic of T-cell lymphomas, and it should not be presumed, unlike solid tumors, that a stage 4 is incurable. I think there are patients that we see with very advanced disease that still have a high chance of potential cure and response. I wanted to go over some of the treatment strategies, both in the upfront and the relapse refractory setting. I think we can broadly put them into these 4 categories. Chemotherapy, which can come in 2 varieties, the multi-agent or many different chemotherapy agents lumped together that have broad activity, but they do not have a specific target. There are targeted chemotherapies, such as brentuximab, where you have a specific target, and so it's easy to kill cells that are expressing that target, but not the other cells around it. We have what is called as more biologic or rationally designed therapies. I have put them under 3 small categories of epigenetic modifiers. These are drugs that can give signals to the genetic makeup of the lymphoma cells to turn on and off to survive, to evade escape from the immune cells or to undergo apoptosis or death. There are small molecule inhibitors, which are drugs that have been specifically targeted to alter or correct signaling pathways in these lymphoma cells. And finally, the immunotherapy platforms that include immune checkpoints, bispecific antibodies, and more cellular therapies. Stem cell transplantation still is pursued for a lot of patients with T-cell lymphomas. These come in 2 varieties. The autologous stem cell transplant, which means that the stem cells have been harvested from the patient, and allogeneic bone marrow transplant, which means that the stem cells have been obtained either from a HLA-matched related or unrelated donor, or in some cases, a haploidentical donor or an umbilical cord donor. And finally, radiation, which is often used to consolidate or as a palliative strategy. So I would like to mention that most of the discussion today about treatments will mostly apply to the 3 most common types of T-cell lymphomas, which is PTCL-NOS, AITL, the angioimmunoblastic T-cell lymphoma, and anaplastic large cell lymphoma. Multi-agent chemotherapy such as CHOP, CHOEP, CHP plus brentuximab now, and dose-adjusted EPOCH remain more or less the standard of care in the upfront setting throughout the U.S. and also throughout the world. I think it is very common for lymphoma doctors such as myself to use one of these upfront strategies in the treatment of patients to obtain a PET after 3 cycles to determine response. And if we are able to induce a response, such as at least a partial remission, we will proceed to finish the remaining 6 cycles of chemotherapy. And at that time, if the patient continues to remain in remission, to consolidate it with an autologous stem cell transplant. However, in the chance that a remission cannot be achieved or it's just a stable disease, I think it's imperative to start thinking about either a clinical trial, which is always preferred in the context of T-cell lymphoma, or an FDA-approved second-line treatment. I wanted to bring up brentuximab because this is one of the most exciting and targeted therapies that has revolutionized the way we treat anaplastic large cell lymphomas that are CD30 positive. So brentuximab is a targeted therapy. It's a targeted chemotherapy where the target is CD30. So the tumor cells of anaplastic large cell lymphoma patients, whether you're ALK positive or ALK negative, express CD30 on their surface for majority of the patients. And brentuximab will attach or bind to this target on your tumor cell, and then on the other side of it, it has a drug connected to it, and this will help. This process of binding will then lead to internalization of this drug inside the lymphoma cell, and then will push the lymphoma cell towards a death pathway. Based on very exciting phase 1 and phase 2 studies that were done with brentuximab in patients with T-cell lymphoma, it was eventually studied in the context of, in the setting of upfront treatment of patients with anaplastic large cell lymphoma. And this is the echelon 2 study, which is a large randomized phase 3 study involving multiple sites and many different countries, where patients with anaplastic large cell, where patients that expressed CD30 or more in 10% of their tumor cells were randomized to either the standard treatment, which is CHOP, or they received CHP, which is the same 3 drugs, CHP of the CHOP, but instead of O or Vincristine, it was replaced by brentuximab vedotin. And what this trial showed was that in patients with, specifically with anaplastic large cell lymphomas, there was a higher response rate, progression-free survival, and overall survival with the brentuximab containing arm, thereby making it a standard of care in the upfront setting for patients with anaplastic large cell lymphoma and other CD30 positive T-cell lymphomas that express more than 10% tumor cells that are positive for CD30. A variety, given the very high response rates and the exciting progress that we have made with brentuximab that has been added to an old multi-agent backbone like CHOP, a variety of different agents have been studied in this, have been added to old traditional chemotherapy regimens, and some of them I have listed here. These are agents such as lenalidomide has been added to CHOEP, pralatrexate has been added to this old chemotherapy regimen, belinostat has been added. Unfortunately, with the exception of brentuximab vedotin to CHOP, most of these other combinations of novel agents tied to a traditional backbone have not progressed well and have not come to the phase 3 randomized setting. And this is predominantly because of the high toxicity that was associated with these regimens. Two combination strategies that I wanted to just briefly mention about were one, romidepsin that was added to CHOP and studied in a phase 3 trial where patients were randomized. Patients with untreated T-cell lymphomas were randomized to either receive CHOP or romidepsin plus CHOP, and unfortunately, the trial did not meet its primary endpoint of progression-free survival, and also the response rates were fairly similar in the two arms, and so there has been a decision taken by BMS to withdraw romidepsin from the market. I think because romidepsin is still listed as an approved treatment on the NCCN guidelines for patients with relapsed and refractory T-cell lymphoma, it is still available to us for use. It will also remain available for patients with cutaneous T-cell lymphoma, where there seems to be an advantage. I think one of the exciting trials that is being conducted by the Alliance Group is a trial that is being led by Dr. Neha Mehta Shah, which will look at the combination of CHOP or CHOEP plus oral azacitidine versus CHOP or CHOEP plus duvelisib compared to the CHOP or CHOEP alone backbone. This trial has just started accrual and is being activated at other sites. I think this trial has also been integrated with a lot of correlative studies so that we can stratify and understand both biomarkers of response and resistance to these strategies. So I think a question that often comes is that what do I do when my cancer recurs or when my cancer has never responded even to the upfront treatment? And the way we think about these scenarios are by stratifying them into these two categories. So a term that you may have heard your doctor use very often is refractory disease, which is that this patient has probably never had a response, a complete response to first-line treatment, or patients with relapse disease, which means that the patient initially had a complete response, but eventually the cancer returned. So what do you do in a situation like this? The answer, once again, is participate in a clinical trial. If you are unable to participate in a clinical trial, either because it's not available to you or because you're not eligible, or whatever the reason might be, you then have the option of a few different agents that have been approved by the FDA in this scenario. And these include drugs such as belinostat, which is a HDAC inhibitor. It's an epigenetic modifier. Brentuximab that we just spoke about. Pralatrexate, which is an antifolate. It's a chemotherapy similar to methotrexate that you may have heard, but it has a more specific activity in patients with T-cell lymphomas. Patients can use other kinds of non-overlapping chemotherapy regimens, such as ICE, generally ICE, DHAP, GEMOX. These are based on ifosfamide, platinum, or gemcitabine containing backbones. Or alemtuzumab, which is an antibody-based therapy to CD52. So if you have a tumor that expresses, patients have tumors that express CD52 on their surface, alemtuzumab can be a very effective strategy. There are, again, there are some traditional chemotherapy options, single agents such as bendamustine. And then finally, crizotinib, which is a very exciting option available for patients that have ALK-positive anaplastic large cell lymphoma, where high responses have been seen. Lenalidomide is an immunomodulatory drug, which means that we do not really understand how it works because it targets many different pathways in the patient's tumor and the tumor microenvironment, but nevertheless has shown responses in specific subsets of T-cell lymphomas. And finally, mogamulizumab, which is an anti-CCR4 antibody and approved for patients with relapsed and refractory cutaneous T-cell lymphomas after they have failed 2 lines of therapy. This is a slide to just highlight the overall response rates of these various drugs in the second-line setting. So we can start from the top here. Pralatrexate that has an overall response rate of 20. That in the registration trial, Propel showed an overall response rate of about 29% with a complete remission rate of about 11%. Similar results were seen with the 2 single-agent registration studies of romidepsin. The BELIEF trial, which led to the FDA approval for belinostat, and chetamide, which is right here. This is another HDAC inhibitor. I think what is important to notice is that with the exception of brentuximab vedotin again, and crizotinib, which is an ALK inhibitor specifically for patients with ALK-positive anaplastic large cell lymphoma, the response rates still remain very low in the 20 to 30% range, with complete remission responses in the teens. Hence, once again, I think it's important to emphasize that clinical trial is always preferred even in the second-line setting. So what about how do we make these responses better? And another thought that has been circulating for some time among physicians is addition of either adding novel agents to the combinations of old regimens, or adding different novel combinations together that are likely more rationally designed and more scientifically informed. And this is a cartoon to highlight some of these novel combinations that are being studied in the clinical trial context, or some of them have been already studied in a phase 1 and a phase 2 trial and are on their way to a phase 3 randomized study. And one of the combinations that I would like to highlight here is the combination of azacitidine and romidepsin. So azacitidine is a DNA methyltransferase inhibitor, and romidepsin, as we mentioned, is an HDAC inhibitor. So these are both epigenetic modifiers. So 2 different single agents that were combined based on preclinical data and have showed a high response rate, as you can see here, in the 70% range, with a high CR rate in the 55% range. Now, I would like to mention that most of these responses and high rate of complete responses were predominantly seen in patients that were harboring epigenetic mutations, such as in the DNMT3A, TET2, or IDH1 and 2 genes. And so these patients are mostly patients that have the T follicular helper cell kind of T-cell lymphomas, and patients with AITL that seem to benefit more from these combinations than some of the other subtypes. I think we should talk about some of the emerging drugs that have created both buzz and excitement in the T-cell lymphoma world, and one of these are the class of PI3 kinase inhibitors, and this is predominantly due to the fact that there is alteration and dysregulation of this pathway found in a variety of different types of T-cell lymphomas. The two drugs that I would like to mention under this class of drugs are duvelisib and tenalisib. These are both oral PI3 kinase gamma delta inhibitors. They have both been studied in a phase 1 trial and have shown a high response rate. Duvelisib has progressed to a phase 2 trial now to optimize the dose and is further along in its clinical development and once again likely to get FDA approved. Another class of drugs that is equally exciting is the JAK-STAT pathway, again, because of the biological rationale that this pathway is dysregulated and altered in patients with T-cell lymphomas. Ruxolitinib is an oral JAK1, JAK2 inhibitor that, once again, in early phase clinical trials has shown response rates in the 20 to 30% range with durable responses seen in some patients. Ruxolitinib is now being studied in the combination is being studied with duvelisib in the context of a clinical trial, and we hope to get updates from these trials at the upcoming ASH meeting. Another drug that is of interest is sergulatinib. Sergulatinib is an oral SYK-JAK inhibitor that has shown high response rates in patients with relapsed refractory PTCL and CTCL. I think it's important to at least touch upon immune checkpoint inhibitors, although they have not shown that kind of dramatic responses across the common subtypes of T-cell lymphomas, that is PTCL, NOS, AITL, and anaplastic large cell lymphoma. However, in patients with extranodal T-cell lymphomas, NK T-cell lymphomas, very high response rates in a small subset of patients have been noted. The studies out of Hong Kong have shown response rates as high as 100% in about 7 patients that had pretty advanced extranodal NK T-cell lymphoma that seemed to benefit from it. A group at Stanford has shown very high response rate in patients with relapsed refractory cutaneous T-cell lymphoma with pembrolizumab. Combination trials of looking at pembro with duvelisib or nivolumab with duvelisib have been initiated, and I would encourage you to participate in these clinical trials or at least talk about them with your clinician. I think it is very important to mention that some phase 2 studies in peripheral T-cell lymphomas were halted because of hyperprogression and very short duration of response. Hyperprogression has also been noted in patients with ATLL, so it's very important to discuss these trials with your clinician and with your T-cell lymphoma expert. I think CAR T cells is another area that is now being actively looked into for patients with T-cell malignancies, and a variety of different CAR T cell trials which have different targets ranging from CD5, 4, 7, 30, CD37 are now accruing patients in phase 1 and phase 2 trials throughout the country, and I would strongly urge and encourage you to discuss these trials with your clinicians and your treating team. Unfortunately, we do not have a lot of robust data that's available from these trials, but I'm hoping that during the course of the next year or two, that we will be able to see some exciting preliminary results from these clinical trials. Finally, I would like to mention some of the research initiatives and efforts that are ongoing at my parent institution, that is NGH. On the preclinical side, we are looking at the efficacy of a myeloid immune checkpoint called CD47 in combination with mogamulizumab, the CCL4 antibody, for patients with T-cell lymphomas. This has been taken based on our work. Dr. Michael Kudadust at Stanford has taken this combination forward to an early phase clinical trial that is supported by ETCTN and is enrolling patients everywhere. We are also looking at KLRG1, which is another very novel immune checkpoint as a potential target for patients with T-cell lymphomas, and we are trying to understand the details of the tumor microenvironment of these patients so that we can design better and more scientifically informed strategies. And finally, a lot of this work cannot be done without preclinical development. And for preclinical development, it's important to develop high fidelity, robust models such as cell lines, mouse models, and organoids. And together with my mentor, Dr. David Weinstock at Dana-Farber Cancer Institute and Abner Lusant at MGH, we have undertaken efforts to develop these models that can benefit the entire community of researchers in T-cell lymphomas. We have several trials, both in the upfront and the relapse refractory setting, that are open for patients at MGH. Some of them are industry-sponsored trials where we are partnering with investigators outside the FHCC and across the country, and some are trials that are available to us and to a few restricted sites. And finally, I'm leading a global effort to understand if multi-agent chemotherapy is truly the right treatment strategy for patients with relapsed and refractory T-cell lymphomas, or should the single agents or the novel agents and combinations of novel agents start replacing those. And finally, I want to just touch upon the Genomics project that we are pursuing under the leadership of Dr. David Weinstock, Steve Horowitz, and Dr. Lou Stout at the NCI, where the plan is to sequence all different aspects of a T-cell lymphoma and to sequence at least about 500 patients so that we can start understanding more about the biology of these diseases and we can start designing better treatment strategies. So I would encourage, if you're interested in these studies, I encourage you to please get in touch with us and we can work with your clinician at the treating institution. In poor, I think it is fairly clear from my presentation that enrollment in clinical trials is always the preferred strategy for an orphan disease like T-cell lymphomas. And unfortunately, the rarity and the heterogeneity of the disease has made patient accrual and enrollment in clinical trials fairly slow, and the numbers are quite low. In order to overcome some of these obstacles, we now have a very organized clinical effort to rapidly accrue patients in a very coordinated fashion to a variety of different investigator-sponsored trials throughout the country. These include major academic institutions throughout the country. And once again, please get in touch with us if you're interested in participating in one of these trials. And finally, what can you do? I think you can do a lot. You should definitely read about it online. There are lots of portals available, such as the Lymphoma Research Foundation portal, the Leukemia Lymphoma Society portal. There's also a Tcell Leukemia Lymphoma Foundation portal available specifically for patients with Tcell lymphomas, where you can understand, you can get more information about your disease. There are Tcell lymphoma experts in your region, and there's clinicaltrials.gov is a very useful website to get to learn about the latest clinical trials in this particular disease, where you can just put in the Tcell lymphoma in the search button, and it will help refine the trial search for you, specifically geared towards your lymphoma. We at Mass General strongly believe that no patient should be left behind, and we are always committed to helping and advancing research for the care of patients with T-cell lymphomas. This is my contact information and email address, so feel free to email us if you have any questions. And with that, I would like to stop right now, and I'm happy to take questions.
Thank you so much, Dr. Jain, for that great presentation. We will now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so the entire audience can benefit from the answers. If you would like to ask a question, please submit your questions through the Q&A box on your screen. We will take as many questions as possible, but if you have a question that doesn't get answered, you can always reach out to the Lymphoma Research Foundation's helpline at 800-500-9976. So for our first question, someone is asking, how do I find a clinical trial near me? And I know you touched on clinicaltrials.gov, but can you go into, I guess, navigating clinicaltrials.gov, I think is more of the, is the question that's being asked.
So I think you can do a search by putting in T-cell lymphoma there. I think it gives you an option, and I think that can very quickly filter down the trials that are relevant for you.
Great, thank you. Our next question is, I have CTCL and often feel fatigue. How can I manage this side effect? So if I understand, the question is that the patient has cutaneous T-cell lymphoma and feels very fatigued. So how to manage that? Correct.
Is that good? Okay. So thank you for that question. It is. I hear you and I sympathize with you. It is a challenging disease. A lot of patients with hematologic malignancies have this issue with fatigue. Either it's a symptom of their disease, or sometimes it's a side effect of their therapy, or sometimes it can just be a cumulative effect of everything. I think things that can be easily fixed are if it's because of anemia. I think if your blood counts are low, your hemoglobin is low, you could feel fatigued. And so it would be important to discuss this with your clinician, making sure that your hemoglobin values are high up. And if you need a blood transfusion, sometimes you may need a brief interruption or modification of your therapy. And these are some ways to mitigate or abate fatigue. I think having a good diet, less stress, and a healthy lifestyle where you're exercising and just keeping your body going is often helpful.
Great. And we have a follow-up question regarding CTCL. What is the most effective therapy for CTCL expressing a CD8 T-cell response?
So I'm sorry, Sarah, do you mind repeating that question one more time?
Yeah. What is the most effective therapy for CTCL expressing a CD8 T-cell phenotype?
So thanks for that question. I think so. There isn't a particular specific therapy that can help patients with CD8 positive cutaneous T-cell lymphomas more than the others. If that's the question, is there aren't any targeted therapies for patients with CD8 positive T-cell lymphomas. So I would follow the usual treatment guidelines and recommendations of your treatment team. About what the stages of your cutaneous T-cell lymphoma, and this just follow the usual guidelines, which can range anywhere from just topical treatments, radiation, to all the way advanced chemotherapy or enrollment in clinical trials.
Great, thank you. And we have another question regarding PTCL and neuropathy. This is a long-term side effect, and it gets worse in the winter. Is there any tips to help manage neuropathy?
Neuropathy. So thank you for that question. It's a challenging question, and my sympathies go to you. It can be debilitating to receive chemotherapy or agents that are neurotoxic over long term. So unfortunately, a lot of the neuropathy can be reversible over time. It just means that you will have to be farther out from the end of the treatment to start feeling better, or for the effects to mitigate. There are definitely agents available to help alleviate the symptoms and the pain, such as Neurontin, Lyrica, or duloxetine. These are agents that have shown to have some benefit in clinical trials. So I would recommend thinking about those and discussing those with your treating physician. Also, if you're a patient with diabetes or have other reasons to have neuropathic pain, it may be important to talk to your primary care doctor and make sure that those comorbidities are well controlled.
Thank you. And we have another question. What does indolent or stable disease mean for AITL?
What does indolent or stable disease mean in AITL? So I think that's a very good question. So I can say that there are patients with AITL. They're not that common, but every so often we see patients with AITL where they have some lymph node involvement, but they are not very symptomatic from their disease. In other words, they do not have, B symptoms such as fevers and chills and joint pains and rash. Some of the other weight loss, some constitutional symptoms that often AITL patients have. So I'm presuming that indolent means that the patients are less symptomatic and their disease is not, their nodal disease is not growing that fast. It is possible that for a small subset of patients with AITL, you may be able, as clinicians, we can just wait and watch them and initiate a treatment when absolutely needed. I do have a few of such patients where I am waiting, and I have adopted a wait and watch strategy with a very frank conversation with the patients that they may need treatment at any point, or very soon in the future, but not necessarily now. I would wait for them to develop some symptoms if the AITL was just incidentally found.
Great, thank you. And for our last question, there is a question regarding, can you talk a little bit about CAR T therapies being studied for T cells?
Yeah, so that's a very good question, and I had one slide there to talk about that briefly highlights the ongoing clinical trials involving CAR T-cell products throughout the country and in China, and I think so. Historically, targeting T-cell lymphomas with CAR T cell therapies has been difficult due to a variety of reasons, which include, fratricide of the CAR T cell product, complete aplasia of the bone marrow, or sometimes contamination of the product that you're collecting from the patients, where instead of getting normal healthy T cells, we end up collecting a lot of malignant cells, and that can lead to masking of the antigen. So those are some of the historical problems in T-cell lymphomas and with CAR T-cell targeting of T-cell lymphomas. Some strategies have been proposed to overcome these obstacles, such as targeting of the gene, CRISPR targeting or editing of the target, choosing targets that are much more overexpressed in the tumor cells versus the T cells, the normal T cells such as CD30, CD37, CD1A, and TRBC1, and there are and other strategies like this. However, these trials have just been initiated, and they're very early in their results. And I hope during the course of the next 1 to 2 years, we will see results from some of these CAR T-cell enrolling trials that are currently looking at CD3, CD4, 8, 7, 5, and TRBC1, including CD37. So we should have more answers in a little bit from now.
Well, thank you so much, Dr. Jain, and thank you for everyone for joining us on today's call. And we hope you find this information not only informative, but hopeful as well. And we'd like to thank again our sponsors for making this program possible, Pfizer and Kyowa. Please remember, if you had any additional questions, please connect with our helpline at 800-500-9976. And at the conclusion of this program, you will also see an email with an evaluation form. And I encourage everyone to fill out this evaluation form, as we truly appreciate that feedback for future programming. And with that, thank you again, and have a wonderful day.